Whilst much of what you've already heard on this tape programme applies to all adult age groups, the elderly tend to have their own sleep problems. Dr. Chris Idzikowski, chairman of the British Sleep Society.
Even with healthy elderly, their sleep tends to become shorter and more fragmented than when they were young. And again, for some of them, that might lead to the development of a more chronic insomnia because they're worried about the way their sleep's deteriorated. But really, it probably is very much the same as one's hair going grey, or for the gentleman, the hair getting thinner. The sleep's simply not as strong as it was and is a little bit more broken. I think acceptance is important, because once one starts to worry about sleep, and that becomes another factor, then you're on the road of getting very disturbed nights.
When we're younger, our sleep naturally falls into 90-minute cycles. Dream sleep occurs at 90-minute intervals, and so do brief periods of wakefulness, though we're often not aware of them. In the elderly, these periods of wakefulness may become longer, while the overall night's sleep may become shorter.
When it starts to shorten, it can be quite dramatic. They might lose the last cycle of the night, and so start getting up or waking up at 6 rather than 7:30 or whatever. But the same rules apply to the young. If they try to maintain regularity of their routines, and if they can't handle going to bed, at least handle the wake-up time or the time they get up, and not try to sleep at awkward times where, say, there may be a lot more light around or whatever, then that all will help consolidate the nighttime sleep. If, on the other hand, they find that they're napping in the afternoon, then not to panic about that, but regard that nap as part of their quota of sleep for the day. So if they're typically a 6-hour sleeper, then if during the night they're just getting 4.5 hours but are picking up 1.5 hours of nap time at lunchtime, then that's perfectly fine. They're getting their quota for the day.
So the message is, please don't worry. It's perfectly natural to need less sleep in older age. Sleep problems among the elderly, and chronic insomnia generally, are very common problems. Some experts refer to them as disordered sleep. But there are also sleep disorders which are less common, though devastating in their effects.
I used to get up at 7 in the morning or 6:30, feeling absolutely shattered every morning, not having had a proper night's sleep. And I used to drive off to work, which is about half an hour or so, and I used to have to stop within about 10 or 15 or maybe 20 minutes at a lay-by to have a sleep before I could go on, and I used to fall asleep in my chair at work. We thought at the time it was because of increasing age, increasing stress at work, or indeed I was getting bigger, fatter, if you like. In fact, I sort of topped almost 18 stone at one time. We didn't realize that there's anything to do with a sleep illness or deficiency.
Businessman Dieter Shaw now knows that he was suffering from sleep apnea. It was diagnosed when his GP referred him to one of the country's leading experts on sleep apnea, Dr. John Stradling of the Churchill Hospital in Oxford.
Sleep apnea is really an extension of a perfectly normal phenomenon. When we fall asleep, our upper airways actually narrow, which is why you can hear somebody's fallen asleep, because they're breathing just a little harsher. If that narrowing, due to relaxation of muscles in the throat, is excessive, then people begin to snore, which is just more narrowing of the upper airway. And sleep apnea is just the full version of that, where the upper airway narrows and collapses so much it's completely obstructed. Just like you can't hold your breath for too long when you're awake, you can't hold it for too long when you're asleep either, but the body has to wake up in order to clear the upper airway and re-inject muscle tone into the upper airway. So the consequence for the patient is that in response to one apneic event, they have to wake up. The problem is, even though they may be waking 200, 300, 400 times a night, they are not aware of waking because those arousals are not big enough for you to look at your watch and say, oh my God, I've woken up again. These arousals are enough to destroy sleep quality, but not necessarily to be aware of them. The consequences are excessive sleepiness. And that means, for example, when anything even remotely boring happens, you will nod off. And obviously the most serious situation would be driving along a motorway when your attention is not occupied. And unfortunately, many of our patients do present with recurrent car accidents. Perhaps less dramatic is falling asleep at work and being fired, falling asleep at home so that people sort of write you out of all that's going on and just assume you're not interested. The consequences of excessive daytime sleepiness are devastating for people at both a social and a work level. I would stress that the symptom is actually sleepiness, which is different from tiredness. We often use the words interchangeably in the English language, but they are different. Tiredness is a sensation of being thoroughly exhausted at the end of the day, a long, hard day's work, and all you want to do is sit in front of the telly and drink a pint of beer or something, but you don't necessarily want to go to sleep. Whereas the symptom of sleep apnea is actually sleepiness, and if you get up and run around, it will pass, just like all sleepiness. If you put enough activity in, you can overcome it. So there are subtle differences between sleepiness and tiredness, and what this condition causes is sleepiness rather than tiredness.
There are several risk factors for sleep apnea. If you have large tonsils which occupy a significant part of the throat, then it doesn't need much additional narrowing of the upper airway to cause the symptoms of sleep apnea. In that case, removing the tonsils will relieve the problem. But that won't help most of the people suffering from the condition, who tend to be middle-aged men with a weight problem.
Unfortunately, the most important and significant risk factor is overweight. And that's overweight in the neck. So neck circumference or collar size is one of the best predictors of whether you have sleep apnea or not. And something like a neck size of more than about 17 inches becomes a significant risk factor for having sleep apnea. It's a simple mechanical compression effect. It's not just large amounts of fat around the outside of the neck, but it's also fatty infiltration of the tissues immediately surrounding the upper airway. So weight is one of the most important risk factors. For most people, the long-term aim is to get the weight down enough for the upper airway not to be threatened anymore. Unfortunately, there are two problems there. For most people, weight loss is a long, difficult, and often unsuccessful procedure. And you can drive a lot of cars off the road while you're waiting to lose weight. I think we probably only have 1 or 2% of people who manage to lose enough weight to cure themselves completely. I think one of the reasons for this is that you probably have to get down to a weight that is lower than the weight on the way up that produced sleep apnea, because you've damaged your throat, and therefore you have to unload it even more for it to be able to cope on its own. So unfortunately, weight loss is a rare solution for us, contrary to what one might expect. So for us, the dominant treatment is a rather bizarre therapy called nasal continuous positive airway pressure, or nasal CPAP for short.
I was given one of these machines that basically just blows cold air down your nose. And, it just cures you overnight.
The idea is that if you can splint open the upper airway and hold it open while you're asleep, then you can breathe normally, you don't keep waking up, and you don't have the daytime symptoms. And the only way we know how to do that is to provide people with some comfortable, soft, plastic and flexible masks that fit over their noses only, not the mouth, just the nose, held on with a couple of straps. And then that is connected via a piece of tubing to a quiet little pump under the bed. Sounds very bizarre and looks very bizarre, but it's 100% effective. You literally breathe at a pressure which is above atmospheric by only a few centimeters of water, a very gentle pressure, which gently opens the upper airway. But it only works when it's on.
I had great difficulties with the machine, which you use by having a mask over your nose at night, and it has to form an airtight seal, which is quite difficult to live with. And you get all manner of funny side effects. You can't sleep on your back, you can't sleep on your side. It makes you terribly claustrophobic, and that's probably the hardest part. And you wake up with a sore bridge of your nose, and you have an imprint on the mask on your face in the morning. And it's quite frightening, really, at times. But then, of course, that's the minus side. The plus side is that you really can't live without it.
I think it's a mark, really, of how drastic these symptoms are to many individuals, that they are prepared to have this kind of treatment. And to give you some idea of numbers, we now look after over 600 people who use this treatment on a nightly basis. And our current prescription rate is 6 a week. Just to give you some idea, there are 6 people a week prepared to have this treatment in order to get rid of their symptoms.
It's like, like you're getting used to an old painting in the family, an old painting, which has got a lot of grit on it and muck on it and the old age patina and all the rest of it, and suddenly it's been cleaned. And you see this in lovely colours again. And that's really how I felt. And it's the most amazing revelation that you suddenly are awake again. It just happens overnight.
So what advice would Dr. Stradling give to someone who believes they may be suffering from sleep apnea?
I think, first of all, they have to go and talk to their own general practitioners and discuss the fact that they have excessive daytime sleepiness and what those consequences are. And falling asleep at the wheel is something that should be taken very seriously by any doctor. And then say that they also have very heavy snoring and that their partners have noticed that they will stop breathing from time to time. They've heard an article or read an article on sleep apnea and they are quite concerned that this might be the problem. Is there anywhere where they could have this investigated? And that's the sort of advice I would give somebody. Unfortunately, because it's a relatively newly recognised condition, not every doctor in Britain will necessarily recognise this as a significant syndrome. We do our best to try and educate, but doctors have a lot to learn about and they won't always necessarily know about this. So if somebody is sort of rejected at the first hurdle and said, well, I don't understand that, then I would offer the advice that they persist and don't give up.
Dr. Stradling is currently researching other treatments for sleep apnea with support from the Sleep Apnea Trust. You can find the address and phone number of the trust on the inlay card with this cassette pack. Another, though very different condition, which is characterised by excessive daytime sleepiness, is narcolepsy.
Narcolepsy is a physical neurological malfunction which causes abnormal sleep tendencies, including excessive daytime sleepiness and disturbed nocturnal sleep.
Michael Sargent, chairman of the Narcolepsy Association UK, who is himself a narcoleptic.
For reasons not yet fully understood, certain chemical messengers send faulty signals to parts of the brain that control all the different aspects of sleep and wakefulness. Sufferers are affected by an overwhelming need to sleep, often at inappropriate times and places. Daily sleep attacks are often frequent and unpredictable, and quite beyond the control of the sufferer.
Lulu Appleton, who's also a narcoleptic, can vouch for that statement.
You have peaks and troughs all day. You're wide awake and then you're very, very tired. You're so tired that you can put your chin in your hands and go to sleep for 2 minutes, and that will refresh you. I had a lot of trouble at my daughter's school play, speech day, carol concert. She always used to ask me to sit at the back. She knew I'd fall asleep. I've slept at dinner parties. I've slept standing up, leaning against a wall. I've actually tuned out over dinner, missed 2 minutes of conversation, and shut my eyes and come back in. Some people notice, some people don't.
There are a number of internationally accepted symptoms of narcolepsy. Michael Sargent.
The main symptom of narcolepsy, as we spoke about, is excessive daytime sleepiness, which would include daily episodes of sub-alertness, enormous lethargy when it's very difficult even to get up and make a cup of tea, to the more dramatic where you get a sudden sleep attack. Narcoleptics can lapse into what's called automatic behaviour. This is where they would undertake routine tasks, often unnecessarily, sometimes repeating them without any later recall of having done anything at all concerning that task. One of the key symptoms of narcolepsy is the ability of narcoleptics to drop into what is called REM sleep, rapid eye movement sleep, which is when you dream.
There's usually a pattern in the onset and development of narcolepsy.
Typically, narcolepsy develops in late teens to early 20s. However, it can develop much earlier and in a small number of cases somewhat later in life. Once established, the condition affects the sufferer daily for the rest of their life. It's a very paradoxical condition whereby a sufferer can suddenly become very alert for short periods, and it doesn't affect basic intelligence or ability to reason. Once developed, narcolepsy probably doesn't vary very much throughout a sufferer's life. What does vary is the narcoleptic's ability to cope with their disability. And that can be affected by many factors, and probably the main ones are changes in your general health, for example, or alterations in lifestyle, or most importantly of all probably the natural slowing process of advancing years.
In fact, middle age can be the straw that breaks the camel's back.
That's when we normally find that people are forced into early retirement, and with the world of work as it is today, that age is tending to come down and down. And that's certainly the position I found myself in the mid-40s. I had to admit that I could no longer work at that level. We all make our adjustments in our own way, but there comes a point in time when you just have to stop and admit that you are disabled. Very difficult when maybe for 20 or 25 years you've been telling yourself you have a problem, but it ain't that bad. And it's important that the full range of symptoms are given to the GP, who, if he suspects narcolepsy, would then refer the patient on to a consultant neurologist for further investigation.
There's no treatment that's specifically for narcolepsy, but many sufferers find that one or other of the stimulant drugs can help control their symptoms. The drugs are simply a way of managing the condition. They can't provide total relief. But Lulu Appleton found that the medication has helped her.
It's given me a full working day, and it's given me a full night of sleep, because the medication scoops up all the pockets of tiredness and then delivers them in one fell swoop at night, so you have a decent night's sleep.
Narcoleptics can also receive support from the self-help group, the Narcolepsy Association UK.
We are a group of sufferers and carers who pull together to try and support and help each other, and to help sufferers who have not yet been diagnosed along the pathway to diagnosis and understanding of their condition. In doing this, we produce a range of informative booklets, we produce a newsletter, and of course we have occasional meetings in different parts of the country to which people can come, because most narcoleptics grow up extremely isolated. They believe they're the only one. A number of times I've heard, "You're the first other narcoleptic I've ever met. If I had £1 for that, it would make me a very rich man." So it is a wonderful release for people to get together, to be able to talk to people who understand what they mean rather than what they're saying, because of course a lot of these symptoms are inside the head, and very difficult for people to truly comprehend what is going on and the complexity of what's going on.
The address of the Narcolepsy Association UK is printed on the cassette inlay card. The disruption experienced by a sufferer usually spills over into the life of their partner. And that's also true of two other very different sleep disorders, night terrors and sleepwalking. The leading expert on sleepwalking is Professor Arthur Crisp.
Sleepwalking is quite common. I mean, in children and adolescents, perhaps 10 to 15 or even 20% of children have had at least one episode. But in most instances, people grow out of it, so to speak. But it remains a feature in adults in about 2% of the population. And people who have it in adult life will often have had it in earlier life. And it may occur every night, or it may just occur occasionally, in which case it's often stress-related. And adults may well have sort of gone into the closet with it, because by definition they haven't been helped by the caring professions, and it only then presents in later life if complications arise. Now, they can arise if it gets worse or more elaborate, and if there's a risk to the individual. For instance, some people, without knowing it, will be putting their arms through windows and or falling downstairs, or even getting out onto the road and being at risk in that sense.
Professor Crisp recommends a course of action which is best described as risk reduction.
It's important to help the person with practical measures sometimes, so that when these attacks occur, they're less at risk. to damage themselves. I mean, the fallback position would be, wouldn't it, with the problem of breaking a window, to have unbreakable glass, you might think, that kind of thing. Or to ensure that the individual isn't in a situation where they're likely to fall over something or fall down the stairs. But if you're there and they're putting themselves at risk, you can try to help protect them. If you yourself are involved in the activity and they're sort of unwittingly menacing you in some way, then you obviously have to safeguard your own position, and you may need to talk that one through with them when they're awake.
Sleepwalking occurs in the first half of the night, during deep sleep. It's closely related to a condition known as night terrors. Dr. Chris Idzikowski says that this condition should not be confused with nightmares.
Nightmares occur out of rapid eye movement sleep, tend to be very vivid and visual, tend to occur towards the end of the night in the morning. And when it's happened, one's very quickly aware of what's going on around one and the fact that one's had a nightmare. A night terror occurs out of slow-wave sleep, which means most of the cortex, the higher parts of the brain, are still asleep. And it's just other centres that are fired off for whatever reason, and that's then been interpreted by that person as something frightening. Quite often, one feels extremely frightened. Sometimes it feels as if somebody's pressing down on one's chest, and anybody who's with somebody who's suffering from a night terror usually finds that when that person's starting to wake up, that they're incoherent. Sometimes the condition is called sleep drunkenness, and it's very difficult to get anything through to them. There's certainly no problem in trying to wake them up, trying to console them. You're not going to do any harm by doing that, but you just have to be aware that they may be extremely incoherent, but also that there is no worry about that. They will ultimately either go back to sleep or become their usual selves.
The night terror may move on to sleepwalking, or it may subside there and then, and the individual may return to sleep. And they may not remember these episodes the next morning, but they may feel tired if they've had a lot of them because their sleep has been disrupted. If they do waken from a night terror, and whether or not it goes on to sleepwalking, it's often said that the mental content is less vivid than in a nightmare. But in my experience, that isn't always so.
Unfortunately, medication is not a solution for night terrors.
There's no dramatic medical treatment in the form of drug treatment for this disorder. There are certain drugs which are very specific to the individual, and it's a matter of trial and error, really, with the individual. I mean, for some people, beta-blocking agents help. For other people, occasional prescription of temazepam or one of the benzodiazepines can help. But drugs on the whole are not going to be the answer to the problem. And other solutions will include, of course, if the disorder is obviously sensitive to stress in the individual's life, whether or not they recognize it, then there is the potential always for addressing that.
Professor Arthur Crisp. This tape continues with a relaxation exercise presented by Professor Colin Espy, which has been found to be very helpful by many sufferers from sleep problems treated in the West of Scotland Sleep Clinic. But a word of warning, please don't listen to this section while you're driving or using any kind of machinery, or if you're in the bath or near other water. Do wait until you can get home, get comfortable, and get the benefit without endangering yourself or anyone else. We hope you found this programme on sleep problems helpful. Remember that however bad your sleep problems, there are in most cases effective treatments available, and there are things you can do to help yourself. Take on board some of the techniques we've described on the tape and persist with them. Don't expect instant success, and don't give up. If you have a setback, try and think positively again and talk your problems over with a fellow sufferer or a friend. Above all, do something about it. Don't give up. Good luck. Please now turn to side 4.